Hello, everyone. I'm Ryan Mackman, and I'm a business consultant with Salient Healthcare. I want to welcome you to today's webinar about managing inappropriate utilization of the emergency room, which is an especially important topic right now during the pandemic. A few items of note before we get started. I want to inform everyone that this webinar is being recorded, so you will certainly have the opportunity to rewatch the session, and you can even share it with colleagues if you want. Salient Healthcare will also email you a link of the recording and the slides following this presentation. Also, during the webinar, you'll be able to submit questions to the other presenters and myself using your attendee control panel at any time, and we'll answer as many of those as possible during our Q&A session towards the end. These questions are also being recorded, so even if we're unable to get to yours during our allotted time, we'll make sure to follow up and answer it via email. Now, presenting with me this afternoon, we have Amy Koch, our principal business consultant, and we also have Maria Nicole, who's our senior business consultant. And this webinar was put together based on our experiences. What we've found is that ACOs often struggle to deal with beneficiaries that are using the ER as their primary care provider, or just for issues that are better handled either by their PCP or an urgent care center. It's even worse during the pandemic situation because of the influx of COVID-19 patients that inevitably take over the primary focus of the department. In fact, on a personal note, I have a cousin who's an ER physician in the Milwaukee area, and from the stories that I hear from him, you'd be surprised at how some patients view the ER as their primary care. And I'll get into some reasons why they perceive the ER the way they do in a little bit. So we're all in population health with a strong primary care focus, and part of best practice in our industry is getting to know the patient so well that you've developed a true patient-physician relationship. The idea being that those patients would choose primary care over running to the nearest ER really should be a core initiative. Inappropriate utilization of the ER has become one of the biggest impediments to accountable care organizations' efforts at managing their population's quality of health and achieving shared savings. And that was so even before we had to deal with COVID-19. Now there's a pandemic to contend with at the same time. So what exactly can an ACO do to continue to achieve their goals? As with all things ACO, there's never just one solution to an issue, but by tracking ER utilization with the Salient Healthcare solution, you're enabling your ACO to conduct continuous process improvement. This webinar is going to teach you the importance of increasing access to care, especially during times of a pandemic, in efforts to avoid inappropriate ER utilization. Now, I'm an analogy guy, so if you were here for one of the last webinars that I was a part of on HCC risk scoring, you're probably used to that already. In this case, with regards to ER utilization, my analogy is going to be the grocery store. So when you go to the grocery store, there's always one checkout lane that's dedicated to those who have 10 items or less. The rest of the customers would use the regular checkout lines, or in some cases, if you have it, the self-checkout areas. When all three of these checkout lanes are appropriately used, it's pretty easy to go shopping. But when people with full carts are using the express lanes, which I feel like always happens to me, they end up creating a bottleneck. We can apply that scenario to what's going on in our emergency rooms across the nation as they fill up due to a mixture of more patients and less providers. So now you have one problem, which is inappropriate use making things difficult for the other patients or shoppers, exacerbated by another problem, which is not enough staff to handle the bottleneck that's occurring. So let's discuss a few ER statistics. According to the Centers for Disease Control, Medicare patients currently account for over 18% of all ER visits as indicated by the chart. Not all these visits are actually for emergencies. People are using the facilities, or referring back to my analogy, lanes, for visits that they're not designed to be used for. And everything from how ACOs operate to how the ER itself operates begins to become very inefficient very quickly. Now, that's great information and all, but how does that inefficiency really affect you? Again, referring to the CDC, expenses per office-based physician visits were only about $200 per person, but expenses per ER visit averaged nearly $1,000 per patient. as you can see on the left-hand graph. Annually, there's over 145 million visits to the emergency room, and of those visits, only 8.7% of them resulted in the patients being admitted to the hospital. As I continue to paint this picture for you, you're now looking at a 5-fold cost increase just for choosing to go to the ER. And get this, 91% of the patients who showed up could actually be sent home the same day. That's more expensive for you and more expensive for the patient when not everyone really needed to be there. In fact, in 2016, Medicare expenditures for ER visits exceeded nearly $680 billion. A similar trend applies when a patient chooses the ER over an urgent care center too. In fact, the costs for conditions that can be treated in the primary care setting are 5 to 6 times cheaper when treated at the urgent care center or primary care provider, irrespective of the diagnosis, which is what the graph is on the right-hand side. So now you're an ACO who's trying to provide the highest quality care while decreasing unnecessary expenses. So why are the patients choosing the hospital over their primary care provider when really it should be cost prohibitive? Well, according to studies done by Deloitte, there are 8 common reasons patients chose the ER, and 4 of those could be impacted simply by increasing patient access. Those 4 reasons I'm highlighting included because the doctor's office wasn't open, they didn't have another place to go, the ER was the closest provider, and the ER is their usual place of care. I don't think it's that hard to imagine whether those patients would stop going to the ER if they were aware of other options. Now, I'm going to hand this off to Maria to talk a little bit about the overall benefits of reducing ER utilization. Maria?
Thanks, Ryan. We're going to step away from some of the shocking data, and I'm going to look at the cascading effect of ER utilization reduction. Everybody benefits when ACOs implement the ER utilization reduction initiatives because patients get appropriate care, quality care, and the costs are lower. You have providers that are improving their relationship with their patients, and that mitigates future returns to the emergency room since the patient is more likely to call their provider now. When you implement an ER utilization reduction initiative, it leads to more appropriate ER utilization whereby the hospital is being utilized for its intended purpose, and all of that leads to cost savings. On my list here, I have patients, medical practices, and ACOs. We'll start with patients because patients should always come first. Even if a patient has a great relationship with their provider, but their provider isn't available, the patient is then forced to look elsewhere to receive their care. Issues may arise on the weekend or even the evening, and unfortunately, if the office is closed, they're forced to head to the hospital. By increasing availability or by providers creating relationships with nearby urgent care centers, patients ultimately win because they get the care that they need without having to head to the hospital. An example of that is a practice that Ryan actually worked at. They had an urgent care center just for that reason. Now, not every practice can do that, but it's worth it if you can. If not, build relationships with local private urgent care centers and let your patients know about them too. Telehealth services have had a significant impact lately and have expanded access for patients, especially during the pandemic. This reduces the patient's risk of contracting the avoidable illnesses while also receiving timely and appropriate care at lower costs. By increasing access to care for patients, primary care providers are able to strengthen the patient-provider relationship. This allows them to be available for the patient when the patient needs them the most. With COVID-19, we've seen a dramatic increase in telehealth services. Providers can add access to care through telehealth during the pandemic and also increased reimbursement. Telehealth allows the patient to get the access to their primary care provider while the provider receives additional fee-for-service revenue. I'm sure we're going to see a significant increase in telehealth services used to expand access in the coming months. And finally, let's take a look at the ACO. In consulting with a lot of ACOs, I and the other healthcare consultants frequently find that this is one of the earliest and largest opportunities to reduce spend by curbing unnecessary ER utilization. In an ACO with over 10,000 beneficiaries, millions of dollars can be saved just by focusing on this one area of need. In some cases, this one area alone can be enough to really make an impact and achieve shared savings for the first time. You can use the Salient Healthcare dashboards to compare the average cost per visit in the ER compared to primary care. Each visit is about $400 more expensive in the emergency room. If the ACO reduced ER visits by 10%, the ACO would generate a shared savings of almost $150,000. Now, I think I set the table pretty well here, so I'm going to hand this off to Amy to walk us through the Salient workflow on using data to drive initiatives. Amy?
Thanks, Maria. So let's take a look at a method that Salient consultants recommend using, and that's the decision tree. This tool helps to identify the initiatives your organization may need in order to address inappropriate ER utilization. And, we typically don't write out the decision tree. It's usually a discussion with the ACO administration, since they tend to know this information off the top of their head. But in any case, it's important to walk through the steps and use your data to back up some of those inklings. Sometimes there are practices that may just be hiding under the hood or hiding among the mix of your other providers. And the first step really starts with an analysis of overall utilization, which we're going to measure in per 1,000. So let's turn to the data. Here we're looking at ER per 1,000, and as you can see, the monthly rate is going to fluctuate, but it's hovering around 525 per 1,000, and it's slowly moving in the right direction. Now, this is demo data, but Medicare Advantage, although totally different population with a different set of rules, considers 500 per 1,000 to be a really decent threshold or target that I think ACO should really strive for. Additionally, if the organization has very high ER utilization, way above the 500 mark, maybe 800, 900, 1,000 per 1,000, then you want to see quarter over quarter improvements or year over year improvements. And that's when you're tracking performance over time. Now, ultimately, you need to turn to the data first to understand the direction your analysis is going to take you in. In this particular scenario, at the organizational level, you see that they have a pretty good level of utilization. However, there are definitely going to be some practices or TINs, tax ID numbers, that you want to focus on. So using a drillability function, you could look under the hood and see where your focus is needed. So now we're going to take a look at the TIN level. So once you drill in, you'll get a whole list of TINs. And here we see that there's actually 5 practices that have increased their ER utilization this year compared to last year, and they're way above that 500 goal. So even though the whole organization was at 525 per 1,000, there's a few hidden in here that you really need to focus on. And at this point, it makes the conversation a little bit more customized and appropriate as it pertains to those certain practices and providers. You want to make sure there's enough attribution so that resources are utilized in a meaningful way as well. But these are the necessary steps you really need to take to drive change. So this data then brings us to the next step in our decision tree, which is figuring out patterns of ER use. So we're back to our decision tree. And we need to figure out if the problem is occurring during office hours or when the office is closed, because that's going to lead to different initiatives and a totally different conversation that you're going to have with the organization and your providers. So let's take a look at the data once again to make a decision about when this is happening. Mind you, the answer could definitely be both. So on this slide, we're breaking out the data by days of the week to get an idea if there are certain days of the week when the office is open to see if there's an issue. And based on this demo data, we actually see that Tuesday has the most visits, although I would not expect it just from experience. Typically, Mondays and Fridays have the highest peaks because Mondays are over busy days with major overflow of patients, and the overflow of patients tend to end up in the ER anyway. And then Fridays are another usual culprit because people take off on Fridays and tend to leave the office short-staffed. But here we see Tuesday is the culprit, so we're gonna make sure we do something when the office is open. Now let's take a look at when the office is closed on the weekend. Here we see Saturdays actually have a pretty high spike in visits, so perhaps the answer is actually yes to both. We usually do see high ER utilization on the weekends because the office is closed. Many tend to think their emergency can't wait until Monday, so this leads us to different ways we can address the problem of high ER utilization when the office is closed. So back to our decision tree. If the issue for your organization or practice is during office hours, then you need to create initiatives around education and existing workflows. And if your issue is during after hours or generally when the office is closed, then you're going to need to think about how to expand your coverage. So let's kind of dive deep into those. Here's a list of some of the recommended initiatives to select that will ensure a change. I'm going to walk you through some of these concepts. Firstly, there's the absolute need for provider buy-in. The practice needs to accept that they have a high ER rate or even a high admission or readmission rates and need to take ownership that it's due to the way the office is practicing. Additionally, before any strategies are implemented in the office, the staff needs to become educated as well. Buy-in has to happen at all levels. You're practicing team-based medicine, and so everybody needs to accept that a change needs to occur. When the concept is accepted by the team, which is primarily through viewing your data, then you move to the strategies that they can implement. They may want to tackle their scheduling, for example, by ensuring that the office can accommodate for same-day appointments. Remember, we're not in straight fee-for-service anymore, so that means that changes need to be made to the practice in order to practice value-based care. And that may mean leaving some gaps in your schedule and not overbooking so that patients can be seen immediately. If there is a shortage of staffing, then maybe you want to hire physician extension, such as nurse practitioners and physician assistants. So you want to extend your ability to take care of those patients and accommodate for those visits. If you do decide to help extend office hours by either opening the office early on some days or maybe staying later on others, or maybe doing it every other Saturday or some variation, you're going to need the staff to be a part of those decisions because you're going to need them to work those extra hours. So you guys all know that phrase, shared decision making. It's on the CAPS survey. That just doesn't need to be reserved for only the caretaker and the patient. Shared decision making should occur between the ACO and the providers and their office staff. One final recommendation has to do with the triage process. Many offices still have voice messages that direct patients to the ER, and I want to reiterate that this practice absolutely can be no more. You cannot have your voicemail saying this if you're a primary care provider. There has to be someone who answers the phone who could properly triage that patient. And that may mean someone who either knows the patient extremely well, like their own provider, but if that's not possible, then just have someone who has clinical background and access to the patient charts. This step is going to cut down unnecessary ER utilization and send the patient to urgent care, or maybe even schedule them for first thing in the morning the next day. But anyway, this step is really going to help the patient in the time of need. And what that does is it fosters the relationship with the patient and provider, which then leads to even more reduction of unnecessary ER expenses. So moving into when the office is closed. So what do you do for increasing access to care after hours? Well, it should go without saying that you absolutely need the same buy-in from your providers, and by showing proper data, there should be mutual understanding that there needs to be a change in the process somewhere. Some recommendations are to provide the patients with the provider's personal number. Like I said before, this can't always be done. It's nice to have, but can't always happen. So this is where a practice can do a rotating schedule or use a clinically based hotline that has access to the patient charts. Another thought that was previously mentioned is to team up with a nearby urgent care center. Maria's going to actually walk you through more in-depth concepts about this approach, but ideally, if you work with an urgent care center, you want to make sure they can obtain notes and that they welcome the patient to their office as though they were their own patient, or what we call kind of a warm handshake or warm handoff. Now, more on patient education. So there is an extreme amount of importance and weight that patient education holds in this entire process. Some patients don't call the doctor's office for the mere fact that they just don't want to bother the doctor. You know, when you ask a patient, they say, "Oh, I didn't want to bother you, doctor. You know, it was in the middle of the night." And it's almost like a sign of respect. But with a little bit of education and letting the patient understand that communication is absolutely key to making sure that they get the best care, you can make a difference. It's also really important that you voice new strategies. If you do end up doing a partnership with an urgent care center, or you decide to extend your office hours or work on weekends, or maybe just you have same-day appointments available now, let it be known and do it through easy marketing tactics. The word has to get out, and it should come from the office staff all the way up the chain to the words coming out of the doctor's actual mouth. Everyone has to be in support of the initiatives put forth in order for them to work best. So I'm going to hand this off to Maria, who's going to discuss advanced concepts in reducing ER utilization.
There are a few advanced concepts that Salient's consulting team wants every value-based organization to keep in mind. And while we've titled these concepts advanced, I want to point out that we think these concepts are completely attainable by your organization. However, we really highly recommend that you leave some of these initiatives for a second phase and work first through the foundational concepts that Amy walked us through. One of these concepts is to create a partnership with an urgent care center. Remember, if a condition is primary care treatable, it's significantly less expensive and more convenient for a patient to visit an urgent care center instead of the emergency room. Amy previously noted that you may consider this partnership if your practice doesn't have enough capacity to accommodate your patients during office hours or after hours. Most urgent care centers are open till at least 10 p.m., and it's convenient for a patient to visit the urgent care center if they're not feeling well after work. However, as with all other organization types, there is variation in quality between urgent care centers. So before embarking on a partnership, remember to evaluate the data to identify high value facilities. For example, a low value facility may actually have high antibiotic utilization or high levels of specialist referrals. Additionally, you'll want to make sure that there are several urgent care centers that are geographically convenient for your patients. We recommend geomapping urgent care centers to ensure that your patients have access within a reasonable driving distance. And this will, of course, vary based on your specific location and geography. And once you've identified the organization that you're going to partner with, you'll want to create specific expectations between the urgent care center and the value-based organization. The expectations will typically focus on a bidirectional communication and referrals back to the PCP. Once you've established a collaboration, you'll want to create marketing materials, as Amy mentioned, so that you can really utilize the preferred urgent care centers. Another initiative that your organization might consider is identifying and working with frequent flyers. So these are patients that visit the ER really frequently. Now, the exact definition varies from organization to organization, but we typically encourage organizations to work with patients that visit the ER 4 or more times over a 12-month period. Salient healthcare dashboards can assist with identifying frequent flyers and creating actionable lists so that patient outreach is more focused and you can bring them in for primary care visits. What we're going to typically find is that each practice will have a handful of patients that go a lot more than the 4 times. Here you see a sample of these reports. So on the left, you see a share trend that specifically looks at 12 months of data, but breaks down the visits on a monthly basis. On the right, you see a slightly different view of the same information, but you can actually see the average cost of the ER visit. And as you can see, there's significant savings that can be obtained just by keeping a handful of patients from visiting the ER. You'll maybe want to take a look at those patients' diagnoses. So many of these patients might actually have behavioral health issues or social determinant of health issues. You may consider enrolling these patients into programs like chronic care management or referring them to community resources. And the reason we put these initiatives into the advanced concepts is because we all know that changing patient behavior is pretty difficult, especially for patients that have social determinants of health or behavioral health. So, the last concept that I wanted to talk to you about is obtaining admit, discharge, and transfer feeds, abbreviated ADT. A practice is notified of a patient when the patient is discharged from the emergency room, and you can actually use this data for patient outreach. Now, for anybody that's tried to set up an ADT feed, they know how challenging this initiative presents. And while getting timely, actionable data through an ADT feed is revolutionary for a practice, it's also important to ensure that the data you're getting is easy to interpret, which typically means finding a technology vendor that's going to help you manage the data you get into a clean, reliable work list. Additionally, once you have a work list, your practice will need to develop workflows to complete patient outreach. We recommend that you complete this outreach at the very least to check in with the patient to ensure that their issues have been resolved to avoid future ER visits. You may need to schedule those patients for an office visit, especially if the issue isn't fully resolved. And finally, if the patient is doing well, remember, it might be a really good opportunity to provide that patient with additional education around same day access and after hours access. Your practice may not have the bandwidth or the capacity to do these calls year round, but I've seen practices implement this initiative a month at a time as a way to gather more information on why the patient is visiting the emergency room. While claims data is really helpful in identifying these problems, conversations with your patient about why they visited the ER can be really eye opening for your practice. One practice that completed these calls actually had a frequent flyer tell them that they have a better relationship with their ear physician instead of their PCP. It's super shocking. So, speaking of data, I'm going to pass it to Ryan to talk to us about using data to assess the impact of your initiatives.
Thank you, Maria. Now, after you've identified your areas of opportunity, and you've analyzed the data and you've implemented your initiatives, the next question to consider is how effective were those initiatives? Essentially, we're now back to step one of the Deming cycle that you can see on the left-hand side of the slide. On the right is another screenshot of our salient healthcare dashboards, which is showing the percent change in ER visits by TIN. So you can now go back through those 5 practices that Amy isolated a little bit earlier, and then examine whether any of those initiatives that you've implemented have begun to guide them in the right direction. In order to internalize continual process improvement, you'll actually need to go through this cycle over and over again until your results are where you want them to be. That's really where analytic solutions like Salient come into play. By using the Salient solution, you can quickly gather intel on areas of opportunity and evaluate initiative success. And then when you really want to get to the root causes of particular issues, such as getting at beneficiary patterns, you can then start asking those why questions and take corrective action. Now, aside from the Salient Healthcare dashboards and Salient Interactive Miner, I also want to mention that Salient provides a comprehensive resource library where you'll find additional ER utilization reduction documentation and workflows. You'll also find a copy of this presentation. Our website is www.salienthealthcare.com, and we also have additional literature available on the website if you so choose. Now, up to this point, I've not yet mentioned this, but please don't forget, we offer ACOs a free 45-day trial with your own data, and we'll even run an assessment for you. So if ER utilization is something that you want to focus on, we can certainly do that. Okay, so now I'm going to go ahead and open up the floor for some Q&A. If you have a question for a specific person, just let us know. Otherwise, we'll assume it's just to the general group.
Hey, Ryan. So we did have a few questions come through. Firstly, we had one asking just about whether or not these slides would be made available. I think you just answered this. This will be available both to attendees and will later be listed on our website. But moving forward, we had a question about the source of the data that was shown earlier within the dashboards and within SIM. Could you guys just talking about the source for that data?
Sure. So the data that we shared is demo data, but it's definitely something that you could do with your own information. So if you're an ACO, you have CCLFs, we're able to pull them in, and with our 45-day trial, you could actually take a look at the same analyses with your own data. But I just want to reiterate that was demo data. We're not sharing anybody's PHI or anything.
Thanks, Amy. Just a few more here, as I know we're just a couple minutes over time. What role could specialists play in appropriate utilization of the ER?
So I'll take this one. This is Maria. So oftentimes the specialist will answer patient phone calls after hours, especially if they had a surgical procedure, and the patient may be instructed to contact their specialist. So if the patient does call their specialist after hours, then the specialist should triage that patient and do what they can to ensure that they avoid unnecessary ER visits. And this might mean that your value-based organization will need to establish preferred provider relationships with a specialist to make sure that this message is communicated.
Thanks, Maria. Just had another few come in here, so we'll try to grab these two before we hop off. What if your community only has a critical access hospital and no urgent care centers?
Yeah, so I think you really have to work with what you have in your area. So if you're located in a more rural area, then you have to work with your providers to see how much they can take on their plate, and you could really just do with whatever resources you have. So it's just one recommendation to use urgent care centers, but absolutely having someone who could answer the phone, who can triage as best as possible. Again, a lot of your work will be towards figuring out, did this patient really need to go to the ER, or could we have seen them first thing in the morning? Or maybe we could schedule them the next day, something like that, just to try to figure out, did they really need to go to the ER? And a lot of ACOs we've worked with use Call Me First cards, which is basically like a little business card that you give out as an office, and it says, I'm a part of an ACO. It is preferred that you call this doctor when something goes awry. And there's wording that's on the Medicare website that really tells you what language to use for those types of cards. And those can be really helpful in just kind of reiterating the point of call your primary care if you really aren't sure if it's a true emergency. So a lot of education and background and really just use of the resources you have available to you. So that's basically the best way to answer that.
Great. Okay, and just one last one that had just come in here before we sign off. Within what you guys had shown, Amy and team, how do I see the days when patients are going to the ER?
So your data will have date of service. So you could actually look in whatever system you have to check out the dates of service for a particular type of visit. Maria, do you have anything else you would add to that?
Yep, so the claims information should be able to give you that insight as we've demonstrated in the webinar. So you can look at Monday through Friday and then Saturdays and Sundays. The other way to do that is, of course, if you have an ADT feed, you can always get that data there if you're not able to analyze claims data for whatever reason.
All right, anything else you guys want to say before we sign off?
Yeah, I will take it from here. If that is the last question that we have, I just want to thank everyone for watching this presentation by Salient Healthcare. We look forward to continuing to help you navigate the ever-changing waters of value-based payment initiatives. I'm going to leave this last slide up a little bit so that you have the ability to contact any of our consultants directly if you'd like. Also, please do not forget to follow us on LinkedIn at the address below for updates on future webinars and other resources. With that, have a wonderful rest of your day.